We're very excited about some of the innovation that's taking place in the development of endovascular aneurysm repair. For almost 3 decades now, the endovascular aneurysm repair has been performed pretty much the same way, with evolution in the types of devices, but these devices primarily fall under the same type of classification. The profile, the size of the devices is smaller, but we've not seen much change in the primary design of the device. We now have some devices in investigational stages which address some of the Achilles heel areas of endovascular aneurysm repair. One of these areas is endoleaks. That's one of the primary failure modes of endografts. They may migrate where they're fixed at the proximal neck of the aneurysm, requiring that they either be revised via some endovascular procedure, or that they, in worst case scenario, require explantation, which we have a broad experience with here at the Cleveland Clinic from treating patients like that we see in referral. These endoleaks may also occur because they are branches that feed into the aneurysm, which when we repair the aneurysm in this endovascular fashion, these branches are not treated and are not affected, and so they can continue to allow blood to enter the aortic aneurysm sac. These are called endoleaks. There are different types of endoleaks: type 1, type 2, type 3, and type 4. Different classifications of endoleaks. But this is one of the primary failure routes of endografts. We actually have a device that's in investigational trial now, a trial that we have participated in the early phases and the newest phase of this trial, which has a special inflatable bag, if you will, that surrounds the endograft. And so this inflatable bag is actually distended to fill the aneurysm sac after the endograft, these stents, are actually placed. And what this does is it obliterates that cavity and reduces the risk of these endoleaks. And hopefully it will actually eliminate endoleak and reduce the rate of migration that's even possible, because the stent graft is fixed in the area in which it is implanted. This endobag prevents any blood from accumulating in the sac, and hopefully this will provide a much more definitive role for endovascular aneurysm repair. Approximately 20 to 25% of patients will develop an endoleak at 1 to 2 years. Probably about 50% of those endoleaks will be persistent and will need some type of intervention, and we're very aggressive at the Cleveland Clinic in treating those endoleaks when they are persistent, because we know that that can be one of the primary failure routes of endografts. However, we actually have a publication that demonstrates that even when we're able to successfully obliterate these endoleaks with a combination of glue and coils and other endovascular devices, they may actually either recur, or the aneurysm sac can continue to be pressurized. And so the treatment of endoleaks, once they occur, is not reliable in some cases and is not durable. And so if we can avoid the development of these endoleaks with this newer technology, we will have made a significant improvement in the therapy that we're able to offer for endovascular aneurysm repair.